डिस्प्ले पीपीटी डिस्प्ले डिस्प्ले नहीं दिखा नहीं रहा है ना। सर कर्सर नहीं चल रहा है। इसमें कब ये वाली देखो। स्लाइडर को करती जाओ। इसमें से कौन सी लिफ्टिंग लिफ्टिंग कीर्ति कीर्ति ठीक है। अब से स्टार्टिंग से करेंगे। Now, as we all are recharged, now can we move on to next session on moving, lifting, and shifting patient, which will be dealt by Mrs. Priyanka Kashyap, ma'am, PG nursing tutor, and Miss Kirti Solanki, ma'am, nursing tutor from Rohilkhand College of Nursing. Priyanka Kashyap, ma'am, is MSc and BSc nurse, currently serving as a PG nursing tutor at Rohilkhand College of Nursing, and holds MSc nursing. Possessed more than 4 years of academic excellence, and she got first position as research poster presentation, granted patent on wearable fetal monitoring devices, published research articles in Scopus Index journals regarding childbirth preparation, and also published textbooks on midwifery. Next, we have Kirti Solanki ma'am. She is a BSc nurse and 1 year of clinical experience. Participated in national conferences, attended National Pneumonia Week Awareness Program, and participated in FDP's nursing procedures, competition, and mastering maternal care. Ma'am, I hand over the mic to you.
Thank you so much, ma'am. Good afternoon to all of you. This is me, Priyanka Kashyap, PG nursing tutor from Rohilkhand College of Nursing, with my co-partner, Ms. Kirti Solanki, ma'am, UG nursing tutor from Rohilkhand College of Nursing. A very warm welcome, competency-based hand-on clinical skill training, workshop from faculty development program. Today we will discuss about body mechanics, lifting, moving, and shifting. So the objective of body mechanics, introduction of body mechanics, definition of body mechanics, purposes of body mechanics, some important principle of safety for patient and health workers during moving, lifting and shifting. Some emergency moves, equipment and devices, some common technique of moving, lifting and shifting, types of moving, lifting, and shifting. There are some various steps and various types of moving, lifting, and shifting. Aftercare, conclusion, and references. So today we will discuss about important introduction of body mechanics. Some of the most common injuries sustained by member of healthcare team are severe musculoskeletal strain. Many injuries can be avoided by conscious use of proper body mechanics with performing physical work. Good body mechanics work help restoration and prevent future back problem. Definition of body mechanics. The term of body mechanics used to describe the way we move as we go about daily lives. It includes how we hold our body, when to sit, when to stand, when to lift, when to carry, when to bend, and when to sleep. Poor body mechanics are often that cause of back problem. Injury prevention guidelines include safe patient handling and mobility technique and no lift policies. So here are some anatomical position of body mechanics. Anatomical position refer to a position wherein the individual stand erect, upright position facing the observer. Facing the observer with feet flat on the floor and arm placed at the side and the palm of the hand turned forward. So, some specific purpose of body mechanics to maintain good balance, reduce energy required, avoid excessive fatigue, avoid muscle strain and tearing, avoid skeletal injuries, avoid injury to the patient as well as a staff member. The basic concept of body mechanics include body alignment, body balance, and body coordination. Some important principle of safety for patient and health worker during moving, lifting, and shifting. Before we will discuss about principle of safety for patient and health workers during lifting, shifting, and movement, we will discuss about how different part of musculoskeletal system together. There are some three. There are some three musculoskeletal system work together: alignment, balance, and coordination. It will be maintained by a center of gravity. So what is center of gravity? Center of gravity means imaginary point of human body. So this imaginary point where the entire body weight balances all different parts of direction. So safety principle of for patient. Assess patient general condition before movement. Explain the procedure to reduce fear and gain cooperation. Maintain proper body alignment during the movement. Move the patient slowly and gently, not a harsh movement. Protect patient from falls and injuries. Lock wheel. Always lock wheels of bed and wheelchair before shifting or transferring. Support weak or affected body parts. Protect IV lines, drain, catheter, and tubes. Ensure patient comfort and privacy. Safety principle for health worker. Use proper body mechanics. What are the safety principle of health workers? Firstly, use proper body mechanics. Keep a wide base of support. Bend knees, not the back. Keep back straight while lifting. Use assistive devices whenever available, like mechanical stretcher, electrical bed, like that. Adjust bed to proper height working height. Wear proper footwear to prevent slipping. Use a smooth and coordinated movement to avoid strain and injuries. So let's talk about emergency moves, equipment, and devices. Before discuss emergency move equipment and devices, we will see what to do and what not to do during lifting, shifting, and moving. What to do? Assess the patient before moving. Always assessing the patient before moving, shifting, and lifting. Explain the procedure to the patient. Use proper body mechanics. Lock wheels of bed, stretcher, and wheelchair. Use assistive devices. Ask for help if needed. Keep the patient close to your body. Maintain patient and comfortable. What not to do? Do not twist your back. Do not lift heavy patient alone. Do not rush during transfer. Do not bend your waist. Do not use damaged equipment. Do not leave patient unattended. Do not drag patient on wear. Do not forget safety precautions. So here some emergency move. First move is fireman carry. Used to move a patient quickly from a dangerous situation to a safe place during emergency situation. So first is fireman carry. Used to carry unconscious patient. Fireman carry जो टेक्निक है जो मूव्स है उसका यूज हम अनकॉन्शियस पेशेंट को कैरी करने के लिए करते हैं. क्विकली मेथड टू मूव पेशेंट इन इमरजेंसी सिचुएशन. नेक्स्ट इज ब्लैंकेट ड्रैग. Patient is placed on blanket or sheet. Rescue drag the patient to a safe place. Next is floor drag. Hold the patient. Our clothes firmly drag the patient on the floor to safety. Shoulder drag. Grabs under the patient's shoulder. Drag the patient to a safe place. To rescue, lift the patient using arm and legs. Used to move patient in critical situation. 2% sit carry. Used to conscious patient, each rescue support one side. Pack strap carry. Rescue keep arm. नहीं दिखा के उसमें ना नीचे वाली स्लाइड दिखाई नहीं दे रहा, हम इसको लगा के Thanks. Yeah, he does. Back strap carry. Rescue keep arm close in front of patient, lift and carry the patient. Cradle carry. Used to carry a small and light patient, provide comfortable and support. Next is hand drag. Hold the patient hand firmly, drag the patient to a safe place. Foot drag. Foot drag. Hold the patient feet and move the patient for a safe place. So here's some emergency device equipment. First is transfer device used to used to transfer patient from one surface to another surface. Here are some transfer devices like transfer board, slide board, brake sheet, transfer bed, gate bed, sliding sheet, roller sheet, and pivot disc. Some lifted devices are mechanical lift, hydraulic lift, sailing mounted lift, mobile floor lift, standing assisted lift, patient host, moving devices used for transporting patient like wheelchair, stretcher, emergency stretcher, transport chair. Special devices are spine board, backboard, scoop stretcher, cervical collars. Here some modern devices like electric bed and hover mat like that. Some common techniques of moving, lifting, and shifting. First is log roll method, sheet drag method, transfer board method, pivot transfer technique, lateral transfer technique, mechanical lift technique, gate belt technique, 2% and 3% lift. So first is log roll method used to turn a patient while maintaining spinal ligament, move the patient as unit, ideally for spinal precautions. Second is sheet drag, draw sheet method, used to move the patient up in bed or sideway. Place draw sheet under the patient. Pull the sheet smoothly with body weight and not the arm strength. Third one is transfer board, sliding board method. Used to transfer a patient from bed to wheelchair or a stretcher. Place the board under the patient. Patient slide over the board to the other surface. Pivot transfer technique used to move patient from bed to wheelchair or a stretcher, wheelchair or chair. Patient held by bearing weight on feet, turn in a small step or pivot. Lateral transfer technique used to move the patient from bed to a stretcher or another surface. Usually need two or more helper lift and slide the patient sideways. Mechanical lift used for patients who cannot bear weight and heavy weight. Use a slide and lift as patient needed. Gate belt technique. Use this assistant patient is walking on transferring. Place gate belt around the patient waist and transfer the patient from one to other place. 2% and 3% lift. Used to lift or move a heavy and dependent patient. 2% lift, one at head and one at shoulder. 2% lift, one at head and shoulder, one at knee. 3%, one at head, one at shoulder and back, and one on at his left. So now it's time to procedure for moving, lifting, and shifting. The steps of Here are some steps for moving, lifting, and shifting. First step is moving patient to one side of the bed. Second is the step for moving a helpless patient up in. सर ये ना ये जो स्लाइड आते हैं सारी ये इसको हमारे कंटेनर को सेट करती है तो इसको हटा प्लीज अच्छा नहीं आ रही नीचे तो आ रही देखिए हमारे पॉइंट चल रहा है स्लाइड तो इससे हमारा पॉइंट चल रहा है So, firstly, preliminary assessment. Firstly, check the diagnosis and specific precaution regarding movement of patient. Check the level of consciousness and ability to follow instruction. Next, check for any attachment, example, catheter, IV connection. Check the number of personnel required and available to move the patient safety and provide privacy to the patient. Preparation of patient and unit. Firstly, explain procedure to the patient and maintain IVR like that. Adjust the bed to the working height, lower side rails and lock wheels of the bed, wheelchair or stretcher. Remove all comfort devices used for patient. Check any attachment like catheter, IV line, etc. So now procedure number first is step for moving the patient to one side of the bed. Intra-procedural step. Stand facing the patient at the side of the bed in which he is to move. Stand with a wide waist support with knees and hip flex to bring the arm to the level of bed. Place the arm of the patient on his or her chest. Now place one arm under the shoulder and neck and the other under the patient back. Shift all body weight from front foot to your back foot as you rock backward, bringing the patient towards you to side of the bed. Move the middle part of the patient in the same manner by placing one arm under his back and one under his thigh. Then move the feet and lower legs with the same motion. Procedure number 2. Step of moving a helpless patient up in bed. Intra-procedural step, stand at the side of the patient bed, stand with broad stance, placing one foot behind the other. Flex your knee and bringing your arm at the bed level, put your arm under the patient. Place one arm under the patient's hand and shoulder and one arm under his thigh. Move forward and shift your weight from forward foot to your back foot with flex hip. Count 1, 2, and 3. Shift patient downward to upward. Go to other side of the bed and repeat the above step till the further is patient is positioned satisfactorily. Procedure number 3. Steps of turning a patient to one side of the bed. Intra-procedural step. Move the patient slightly towards the side of the bed opposite to the direction of turning. Position the patient arm. Place the far arm across the chest. Keep the near arm comfortably at the side. Flex the knee of the leg that will be on the top after turning. Place one hand on the patient's shoulder and one other on the hip. Gently roll the patient to one side away from you using proper body mechanics. Place 3 pillow. We need 3 pillow. Place one pillow behind the back. Another one is between the knees. And third one is under the head for support and comfort. Ensure the patient in proper alignment and comfortable. Procedure number 4. Transferring a helpless patient from bed to stretcher. So here are one case scenario. Mr. Rajesh Kumar, a 60-year-old male patient, is admitted the surgical ward after laparoscopic abdominal surgery. He is weak, drowsy, and unable to move independently. The doctor had advised an urgent CT scan, so the patient would need to be transferred safely from the bed to a stretcher. So we need 3 nurses are assigned to perform procedure using correct body mechanics with the follow-up principle to ensure patient safety and prevent injury to healthcare worker. So firstly, nurses explain procedure to the patient. Maintain privacy. Lock the wheels of the both bed and stretcher, and place the stretcher parallel to the bedside. Intra-procedural step. Explain the procedure to the patient. Lock the wheels of both bed and stretcher. Place the stretcher parallel to the bed on the side of towards which the patient will be moved. Adjust the stretcher and bed to the same height. Place the draw sheet under the patient from shoulder to thigh. Roll the edges of draw sheet close to the patient's body for firm grip. Nurses stand on both sides. So one or two nurses on the stretcher side to pull and one nurse's opposite side of support and push. Cross the patient arm over the chest and keep leg straight. On the count 1, 2 and 3, gently slide the patient toward the stretcher using the draw sheet. Position the patient comfortably on the stretcher. Raise the side rails of the stretcher for safety. Cover the patient properly and ensure comfortable. Procedure number 5. Step of assisting a patient to sit on the side of the bed. As we know, dangling position. Patient the arm on the turning side. Bend the knee that is further from you. Place the arm that is further from you across your body. Place your hand on their shoulder blade and the other on their hip. Roll them towards you, keeping your back straight at all times. Lower their legs over the bed edges. Place your hand between their shoulder blades, supporting their neck with your forearm and your other hand on their hip. Press firmly on their hip while lifting them to sit. Move your body in the same direction of the action. Move that buttocks forward using your knee to guide there. Repeat on other side to bring patient to the bed edges. Make sure their feet are flat on the floor. Procedure number 6. Step of assisting a patient from bed to chair or wheelchair. In this procedure, as we follow dangling position. So, intra-procedural step, place the wheelchair at the side of the bed with the back toward the front of the bed. The wheel should be locked and placed against wall and or another person. Help the patient to sit on the right side of the bed. Stand in front of patient facing him. Side the patient buttock close to the bed edges. Instruct the patient to stand on command by simultaneously leaning forward, pushing with the foot placed at the back as he straights his legs. Balance the patient on the chair, armchair, side rails, mattress, or helper shoulder. Instruct the patient to lean forward and lower his or her buttocks slowly to sit by bending knees and elbow. provide safety bed to the patient. Procedure number 7. Step of assisting a patient from chair or wheelchair to the bed. Prepare the wheelchair by removing the footrest. Position the wheelchair at the 30 angle. Lock the wheelchair breakers. Nurses should count 1, 2, and 3. Then both simultaneously lift the patient from the wheelchair on the middle of the bed. Slowly help the patient to lie down by giving support to the head, neck, and place the legs on the bed. Place the patient in correct alignment and make comfortable by giving extra pillow. Aftercare. Ensure correct body alignment and comfortable of the patient. Replace pillow and other comfort devices as needed. Raise the side rails if necessary for the patient, for the safety of the patient. Remain with the patient during changes of position to prevent his or her falling. So now it's time to conclusion of body mechanics. Proper body mechanics are essential for reducing injury risk, conserving energy, and maintaining musculoskeletal health by utilizing correct posture, alignment, and movement. By keeping a low center of gravity and using strong muscles through legs and core rather than the back, individual can safely perform activity without undue strain. So these are the references. Thank you.
For feedback, I humbly call Dr. Anita ma'am for her valuable suggestions regarding the procedure. Ma'am, please come.
Well done by the Priyanka ma'am and Kirti Solanki ma'am. Everything is done well. The only thing is, at least you have moved little the wheelchair till here. Otherwise, you've done with the best. It was the best one.
Thank you, Priyanka Kashyap ma'am and Kirti Solanki ma'am for taking us through the journey of body mechanics. It was a marvelous teamwork display. Now, for diving deep into the most important topic in clinical nursing, that is reporting, according to doctor order sheet and treatment of chart interpretation, intake output charting, we have among us Mrs. Poonam Azad, ma'am, Associate Professor, Rohilkhand College of Nursing. She is PhD scholar, MSc and BSc nurse, total experience of 15 years, HOD of OBS and Gynae in BSc, and then working in Mentor Nursing College, worked as nursing superintendent, and she's a forensic certified nurse, CNPD organizer, trained in IAP for CPR, and trained in use of AI in research. Ma'am, please come.
Thank you so much, Akanksha ma'am, and good afternoon to everyone present here. I think all are feeling little bit lazy maybe. So can you raise your right arm? I said right arm, not hand. So that's why I said that you are little bit feeling sleepy or lazy. So now can touch your nose. Everyone knows where is nose. Nose. Touch. And wake up. So Robin, touch your nose. Can touch your ears from like this. Now you can clap for me. It's okay. So thank you, Principal Ma'am, Rohilkhand College of Nursing, Keslata College of Nursing, Vice Principal, Keslata and Rohilkhand. So they have given me an opportunity to speak on a very important topic which we do in a hospital, but we do with a mistake. Just we want to remind that we are doing the mistakes, but we don't listen. So PPT is going to my topic today is recording and reporting. So, what is recording and reporting? Recording is what we are doing or implementing the things when we are in a hospital, right? Or either in a college also, what we are doing, like we are doing this presentation, they are documented, right? So each and everything which we perform in front of or we perform in a hospital, physically that is documented. We should document each and every part. So when we are going on others, after document the order first, then we interpret that document order. We want the things to the patient. We are refusing the things to the patient. And patient is also feeling no human other things.
चल पड़ी थी ना, पहले तो चल पड़ी थी।
सिक्योरिटी अलर्ट कहीं से डाउनलोड की थी।
नहीं नहीं, पहले चेक किया ना हमने।
कहीं से
हाँ तो भाई
Juniors, to perform one role play.
हो रहा है। हाँ हाँ सो
So they are taking handover first.
अच्छा उधर वहाँ मोड़
यहाँ पे खड़ा होता है। देखिए आप सही से, सबने तो 2 फ्लूट डाले हैं, आपने एक ही लगाया है, पूरी नाइट निकल गई।
अरे नहीं, मुझे तो एक ही लग रहा है, एक ही डाला है सर।
नहीं नहीं 2 है, और ये आपने मैनिटॉल लगा दिया, ये सर ने मेट्रोजिल डाला है।
अरे मैनिटॉल ही लिखा हुआ है, समझ तो आ नहीं रहा है, देखो सही से मैनिटॉल ही लग रहा था, मैनिटॉल ही लिखा हुआ है।
ये नहीं, आप सर से पूछिए, ये मेट्रोजिल है।
अरे मुझे पता है, तुम सर से कुछ पूछ लेना, मैं क्यों पूछूंगी?
नहीं नहीं, मैं नहीं पूछूंगा, आप पूछिएगा।
देखो मुझे पता है, ठीक है, और मैंने
नहीं, ओवर नहीं लूंगा आपका, आप सर से पूछिएगा, कंफर्म करिएगा।
तुम खुद जाके पूछ रहे
नहीं नहीं, मैं क्यों पूछूंगा, आप पूछिएगा।
What happened here? We have a documentation that mother is not ready to accept that she has done a wrong documentation, wrong input after starting. Even the person who is taking the handover, he is saying, and he is also not willing to accept that I will go to ask the doctor. So, there are so many things now. So next, my subtopics, doctor order sheet, interpretation I have given. So, first I will go with this because हम एज अ नर्स अगर काम करने के लिए जाते हैं तो हमें डॉक्यूमेंटेशन से पहले हमारे राइट्स ऑफ एडमिनिस्ट्रेशन पता होना चाहिए. व्हाट आर द राइट्स ऑफ एडमिनिस्ट्रेशन? तभी हम किसी चीज को, अगर हमें यही नहीं पता, वी डोंट नो दैट व्हाट आर द राइट्स टू एडमिनिस्टर, व्हाट आर द थिंग we have to do, we can't record or report to the other person. So here I am looking. First there are 16 rights of medication. Already Shikha has taken these rights. Earlier it was 5 rights only. When we were studying, we have studied 5 rights. These right, drug, rose, right, root and right. And then again, they added right documentation because they have seen, the authorities have seen that agar we are not documenting the things, then there will be chaos in legal, ethical matters. Right? So they have given right documentation. Then right reason. If we are giving the drug, we should know the right reason why we are giving the drug to the patient. If we don't know, we'll go and write. Likewise, nowadays nurses are doing. They are in withdrawing the drug and they are infusing the patient, but they don't know what is the action and they even don't know what to tell to the patient. So we should know right reason, right response. We should know the right response. Okay, if I have given diclofenac, then what will the response? It will relieve the pain or not. If I am giving vomiting MSAT, then it will relieve the vomiting. So likewise, we should know the right response. Then we should educate the patient also. Because nowadays patients are not literate. They are educated. So they will ask us that what is this? Right? Why you are giving me this injection? This is very big injection. You are loaded very fluid. Why you are giving? So right education also be given to the patient. Right to refuse. Patient can refuse for the drug. अब ऐसा नहीं है. This is not the thing that आप गए और injection लगा दिया. It's not like that. Now patient has right to refuse the drug. So आपको उसको alternative ढूंढना है then. वही हमारा documentation है. If patient refuse to take an injection, तो आपको क्या करना है? Document करना है that thing. That we have to take negative consent of the medication. Negative medication consent to be taken from the patient with sign and signature, with witness and with the doctor. Right evaluation, we should, if we have given the thing, now we have to evaluate the what patient has now feel. How he is feeling? Pain relief हुआ कि नहीं हुआ? Vomiting हटी कि नहीं हटी? If we have given the drug. Right form. Check correct drug form. किस form में आ रहा है? It is in vial, ampoule, or it is powder form. It is translucent. It is so many times I have seen in the hospital there are nursing NS, normal saline, which is light in color and which is very transparent in color. So we should know all these things. Right allergy, एनी एलर्जी तो नहीं है, लगा दिया आपने, उसको एलर्जी हो गई, आपको एलर्जी का पता था फिर भी आपने लगा दिया. तो these all things should be the right interaction. आप जैसे मैडम ने अभी शिखा मैम ने आपको इंजेक्शन लगाना सिखाया है, तो हमें क्या करते रहना चाहिए? We should always communicate with the patient. करते वक्त कोई भी प्रोसीजर करते वक्त we should be interactive to the patient. Or right expiry, checks expiration date. Expiry date should be checked before administration to the patient. So introduction I have told already. Recording, what is recording? What we are doing to the patient is all recorded. Examples of recorder are doctor sheet, medication administration sheet, vital sheet, intake output. Already have told you, nurses notes, treatment chart, doctor order sheet. Now what is reporting? Reporting is what you have done to be transferred to the other person. That is reporting. First, what will be to whom you will transfer the information? To whom you will transfer the information first? What you have done? To the coming shift person. Right? है ना? अगर कोई कॉम्प्लिकेशन है देन ड्यूरिंग द शिफ्ट किसको इन्फॉर्म करोगे? टू द डॉक्टर. और इफ यू आर डन योर शिफ्ट then you will transfer this information to the next shift nurse staff, nurse officer. ठीक है? Then she will again go for the further. We are having 3 shifts in our duty hours. So reporting is which we are giving a report to the person like shift wise, to the senior or to the administration. That something happen in the ward, like in sometimes we have some problems in the hospital, in the ward. So that should be reported and recorded and informed to the seniority persons. Then types of here is shift handover report, oral report, written report, telephonic report. Instead, now we have started with WhatsApp reporting also. So now we are whatever it is happening, we immediately put on WhatsApp group. So that is informed to each and every person who are to be informed. प्रिंसिपल्स ऑफ गुड रिकॉर्डिंग एक्यूरेट एंड फैक्चुअल होना चाहिए. ये नहीं कि आपने करा कुछ था और आपने इन्फॉर्म कुछ कर दिया. इट शुड बी फैक्चुअल, क्लियर कंसाइज होना चाहिए, मैसी नहीं होना चाहिए. राइटिंग में है तो राइटिंग क्लियर होना चाहिए, आपका वर्ड्स आपके क्लियर होने चाहिए. टाइमली डॉक्यूमेंटेड मींस यू शुड रिकॉर्ड एंड रिपोर्ट टाइमली. टाइमली मींस अगर आपने आज कोई इंसिडेंट हुआ है और आज आपके साथ कोई इशू हुआ है, you are reporting after 1 month. So it should not happen like this. We should record timely, legible handwriting, use of standard abbreviations, signed with name and designation. This is very important topic. This is very important part that you are informing to anyone. You should sign with your full name and with your registration number. Okay, you should always do this. Types of records, already I have told you, these are the records: patient sheet, nurse sheet, treatment intake and medication. So there is it is visible. So this is the progress sheet. So what ये इसमें हो रहा था पहले, कोई बात नहीं. You all are having your progress sheet. So you all are having your progress sheet. So here it is mentioned identification data. Here we have identification data first. So this is the sheet which is written by the doctor, right? So progress sheet में सबसे पहले क्या लिखा हुआ है? US number. So then there is the name of the patient, then there is the ward, right? So if we are taking US number, what is the importance of US number? Name can be same, age can be same, father's name can be same, but the number can't be same. 1, 2, 3, 4, 5, 6, 7, 8. Sometimes USID number is the main important one. You don't need a patient name if you don't have patient name, but you have USID number, you can get everything of that patient. So we should always write this name. Many of times we are seeing, we are observing in the hospital, you have also seen no nurse or any student nurse is writing this data, or even doctors. They are coming and taking the progress sheet and they are writing their orders. But they should write, or we should write all identification data here, right? So next there is a date, there is a column date, there is a column of progress, there is a column of treatment. There is a column of treatment. So in date, what we have to write here? Date and time of date and time will write. Which date and time will write? Yesterday or tomorrow or coming day? Today. Today is 22. 5/2026, right? So now here we have written the date. Then what we have to write now? Time when this order has to be written. We will write a time. Means doctor will write the time on this date and time to be mentioned here. Then in progress. Progress means what changes are there in the patient, or what is the chief complaint of the patient right now, right? So progress where we are writing vitals, we are writing GCS of the patient, we are writing investigation of the patient. If anything happens to the patient, we are writing or we are advising to the patient, it is written on the progress sheet. Then there is a treatment where treatment is written. So in treatment, they have written day 1. Then there is fluid, they have mentioned. Then there is a diagnosis. Then they have written the treatment. So there will be a treatment written on the treatment column. So all are seeing this, right? In your papers. So line of treatment also should be mentioned properly. Line of treatment means what patient needs and how to write the progress sheet or how to read the progress sheet. Likewise, they have done mannitol, metrogyl confusion. They have done normal saline 500 and 1000 ml confusion. So it should be not like this. So there are some protocols to write the progress sheet. It should be in capital letters. The treatment part should be in capital letters. That should be read by everyone. अगर ये शीट मेरे को मिली है तो मैं इसको रीड करने पा सक रही हूँ कि नहीं. अगर ये पेपर किसी और को, कई बार ऐसा होता है ना, नर्स और डॉक्टर का कम्युनिकेशन अच्छा होता है तो दे नो कि डॉक्टर ने क्या लिखा है, वो पढ़ लेते हैं. दे नो दैट व्हाट वी आर राइटिंग, है ना. सो वो इजीली रनिंग में लिख देते, अच्छा सर ने ये लिखा है तो मैं यही ट्रीटमेंट शीट में लिख देती हूँ. तो इनने क्या करा है, वो नहीं होना चाहिए. रनिंग हैंड नहीं होना चाहिए डॉक्टर का. इट शुड बी इन कैपिटल लेटर. इट शुड बी इन आवरली. The treatment should be written in hourly. Here we are in treatment sheet, we are seeing a time and route. So everything should be written in capital letter. It should be in hourly alphabet, or the abbreviation should not be used. Abbreviation OD, BD, TDA should not be used in your progress sheet. It should not be there. If it is there, then what you will do? If it is there, then you will instruct or you will request to the doctor, please don't write in small letters. Please don't write ODPD. Please don't write this type of things in our progress sheet because it is seen by others also. Right? So क्योंकि एक फाइल जो है बहुत जनों के पास जाती है, फाइल जाती है पहले पेशेंट की नर्स के पास, डॉक्टर के पास, फिर वो जब डिस्चार्ज होता है तो कंप्यूटर ऑपरेटर के पास जाती है, कंप्यूटर ऑपरेटर के पास से वो एमआरडी डिपार्टमेंट में जाती है, एमआरडी के पास ये लीगल डॉक्यूमेंट बन जाता है. ठीक है. तो लीगल डॉक्यूमेंट कई तो फाइल की केसेस होती है, कई पर जो हमारे किसी के कंप्लेंट्स के रिगार्ड से होती है, तो everything should be visible and visible. Then we will write here short name. To write the progress sheet, it should be written in short. First brand name, then short name. Because in our hospital, in every hospital, अगर बाहर भी जाएंगे, आपने यहाँ से लिखवा लिया, आपको ब्रांड यहाँ पे हम जो दे रहे हैं वो लिख के देंगे, लेकिन आप ले रहे हो बाहर से और आपको ब्रांड बाहर नहीं मिलेगा, तो आपको क्या करना है? You will ask the doctor to write a short name also. So it will be easy to get the medication from the कहाँ से? स्टोर से, राइट. Components of the orders है date, time, patient. I have given all the things here. I have instructed you all things here. Then this is the sheet which is given date and time. Then RX. Every doctor is writing RX here. You have seen in your sheet also, progress sheet is written here. In a side, abbreviation RX. It is known as superscription. Then medication जो लिखी जाती है, inscription होती है. Then any advice subscription है. There is a signature, right? So parts of the prescription क्या होते हैं? Superscription, more commonly RX is an abbreviation of Latin words receive. It means receive. It means that throw or you take, please. Inscription क्या? Body of the prescription consisting of the official names and amounts. Subscription क्या है? It provides direction to the pharmacist or dispenser. Transcription क्या है? Direction to the patient, contain instruction about the amount of drug, time and frequency and dose to be taken. Signature is prescription should be signed by the prescriber. So these are the prescription parts. What will be the nursing responsibility in these? Read order carefully, clarify unclear orders. Likewise, I have told you, you should ask. You should not feel shy if you are unable to read a progress sheet. You should not feel shy. Don't feel egoistic also. Sometimes you have seen your senior is there and she is saying, मैं नहीं पूछ रही, मुझे पता है कि क्या हो रहा है. So you should not feel egoistic. You should not feel shy. And you should not do the wrong thing if you don't know. Report any abnormal findings. Then I will go for treatment sheet. Treatment chart is, what is treatment chart? It is for nurses. Treatment chart. This is for the nurses. To collect the medication. What is written by the doctor? We will not interpret in doctor order. We will write as it is what is written in the doctor sheet. Right? So, treatment chart is a written or electronic record used to document medication, treatments, procedures, and nursing care provided to a patient according to the doctor's order. Objectives of treatment chart is to ensure correct treatment administration, to maintain continuity of patient care, prevent medication error, provide legal document, monitor patient progress. Components of treatment sheet as in progress sheet, there is also some components, same identification detail, date and time, doctor order, medication name, dosage and route frequency, nurse's signature, remarks or observation. Interpretation, now we'll do interpretation in this. Patient ID will write name, UHID, IPD number, identify with rights, check correct drug and dose, what it is written mg, ml or units, verify date and time. Date and time means date we have written, time means 6 hourly, 8 hourly, 12 hourly or 24 hourly. What is 6 hourly now? 6 hourly, 4 times a day, and 12 hourly, 2 times a day. So 24 hourly, 1 time a day. So we should write only in hour. We should not use abbreviation. Patient response will check after infusion. Missed or delayed doses which should be recorded and reported. Monitor side effects if there are any. Types of treatment orders, progress, orders can be shared orders. First, we should know patient comes in the hospital. What will be the order? It will be shared order because patient comes to you now. So, what three complaints he or she is having, we will give like that. Medication will be given like that. Then routine order, after stat order, then it will convert it to routine order to the next day. Doctor will write routine order. Then single order given once only. Some medications are there which are given only once. अगर patient came for vomiting, मैंने एमसी का लगा दिया डोज, vomiting subside हो गई, तो क्या दोबारा लगाने की जरूरत है? नहीं. So likewise, single orders are also there. PRN orders are also there, given when needed, right? जब जरूरत होती है जैसे SOS, some drugs are given like that. ये ओपन ही नहीं हो गई है. पहले ओपन हुई थी से पहले हुआ था जब मैं पहले चेक करके गई लेकिन क्या होता है गणित में आपको बताना है कि आपको पता ही है फ्रीक्वेंसी ओरल मेडिकेशन इंजेक्शन ऑलरेडी डिस्कसिंग suggestion I just want to write down just want to evidence sections are there. Here passive sections means if patient is having diabetic, patient is in on insulin, patient is having intubation. So you can write their prenatal parameters. You can write their insulin, how much insulin we are giving, twice or thrice or need. And special instructions means if fluid is given, infusions are given. So we should write on this. There are special instruction part which is given in your treatment sheet. Then other part is your intake output. So these three pages are interrelated to each other. There is a doctor order, there is a treatment sheet, and according to the treatment sheet, you are putting the intake output. So intake output first, उससे पहले we should know what is the normal intake output of the blood of the children. ठीक है, intake output we should know. This is the parameter age group wise. Adults should have 2000 to 300 ml intake and output is 1500 to 2000 ml output. So we should know this. Then only we can make electrolyte imbalance or balance, right? If we are giving more, if we are giving less, we should know. According to the age, body weight, climate, physical activities, fever, disease conditions, medications, these are the parameters we should know when you are giving the patient in or out. So in intake output, I would just want to show you one slide. As it is. Periods of planning and measurement of intake output. So this is the slide. There are three shifts. So in your sheet also we are having three shifts. You might be seeing total here, total in there also. Okay. So duty hours are 8 to 2, 2 to 8, or 9 to 8. Here we are having 8 to 3, 3 to 9 and 9 to 8. Every shift intake output should be mentioned in total, right? In your sheet there is written NS infusion 3 means 1500 ml. 1500 ml you have to infuse to the patient. कितने rate पे? Your there will be different in 100 ml per hour. So what I will do? मैंने अगर उसको 8 बजे दिया है 700 ml. तो 100 ml per hour में कितने घंटे में चला जाएगा? 5 hours में. तो आपको कहाँ एंट्री करनी है? वेरिएबल एंट्री. अगर आपने 8 बजे लगाया है तो हाँ 12 o'clock you will enter there. ठीक है 500 ml NS. Then again you have to infuse 500 ml. Where you will write? Where you will write? 12 के बाद ही बाद में लिखोगे ना. 12 जहाँ पे खत्म हुआ there you will start with 500 ml. Right? So then 100 ml भी जाना है. कितने घंटे में जाएगा? 8 घंटे में. लेकिन आपका आवर बच रहे हैं आपकी शिफ्ट में 2 आवर. तो कितना चला गया? 5 से You have infused 1000 ml NS in your shift, but what you will write in total? Huh? 700 ml. Then remaining 300 ml कहाँ लिखोगे? Where you will write? Let's not take on total only. When you will give order, you will write the 700 ml, then 300 ml remaining. So when the nurse will come, you will tell that I will infuse how much 700 I have given, 300 is remaining. Now in your shift you have to infuse it, and one more 500 ml you have to give to the patient. So 200 ml कहाँ खत्म होगा next shift में? 5 बजे. हाँ 3 o'clock अगर शिफ्ट शुरू हो रही है तो 5 o'clock के बाद फिर आपने 500 लगानी है, तो कब खत्म होगी वो आपकी शिफ्ट में? आपकी शिफ्ट में खत्म होगी कि नहीं? हो जाएगी. 5 to 9 कितने आवर हो गए? 300 आपने 5 o'clock खत्म किया है. Then you have given third normal saline at 3 at 5. तो कितने आवर में खत्म होगी? अरे स्क्रैच योर ब्रेन्स, कितने आवर में खत्म होगी? दिस इज वेरी इंपॉर्टेंट, दैट्स व्हाई. 5 बजे के बाद 6, 7, 8, 9 और 10. दैट मीन्स it will be remaining 100 ml when you will go. Your shift is at 9. So 100 ml again you will give to the night staff. Right? So what you will write here now? 500 in your shift, 300 in your shift, then not 500, 400 in your shift. And 300 in your shift, how much? 700. So you will write here 700 in your evening shift, and 100 ml you have given to the remaining shift person. अब 100 ml ये बच गया, 1500 हो गया, वो कंप्लीट हो गया. रात में तो 12 घंटे है, वो 1 घंटे में खत्म हो गया. What you will write here? In total 100 ml तो है. मैं अभी इंजेक्शन पे नहीं जा रही हूँ. There might be 100 ml tramadol, 100 ml Tazar, 100 ml. I am not going. I am going for only infusion. So here is 100 ml left in night ना. So night वाला क्या लिखेगा टोटल में नीचे? 900. Sorry 100. Right? क्योंकि 100 ही उसने करा है अपने लिए. तो अब आपकी शिफ्ट का टोटल क्या हो गया? ग्रैंड टोटल में इनटेक में क्या लिखोगे? This total, what was this? 700. What was this? ये कितना था? 4 and 3. 700. ये 100. तो 7 plus 100, 15. You have written as 15. So intake में होगा. I assume there is a 200 ml intake. Now output भी है उसका. Output भी है ना. So output I am not giving you output. Output means 200, 200, 200 आपने कर लिया है. आपने 24 hours में 200, 200 किया होगा 8 to 8 में. तो मैंने आप 200 ml मैंने इंटेक दिया और मैंने इसको 3000 आउटपुट में शो कर दिया. ठीक है, आउटपुट शो कर दिया. Then what will happen now? What you will make as total intake output imbalance. Balance कैसे बनाओगे? Anyone knows how to balance the patient intake output? We will do intake minus output. ठीक है, हम क्या कर रहे हैं? intake दे दिया, आउटपुट कर लिया. Now we will balance the patient, है ना, intake output. So we will go with intake minus output. अब intake कितना था? 2000. हाँ, आउटपुट कितना है? 3000. आउटपुट इज 3000. सो अब क्या हो गया? हाँ, माइनस में कितना हो गया? 1000. सो माइनस 1000 मीन्स it is acceptable. It is acceptable. अगर पेशेंट को हम 500 to 1000 मतलब 500 दे रहे हैं, that is acceptable. If it is increasing from 500, then patient is overfluid. Patient is now overfluid. Minus here means patient is having more intake. We have given more intake to the patient, right? So now we have to balance the intake output. What will we say to the doctor or to the nurse? अब रिकॉर्डिंग एंड रिपोर्टिंग में क्या होगा, हमने रिकॉर्ड कर लिया है कि मैंने 200 दिया, 300 आउटपुट हुआ, माइनस होके माइनस 1000 ml हो गया, तो मैं नर्स को क्या बताऊंगी, मॉर्निंग वाले को, कि मैंने इतना प्रीवियस इनटेक आउटपुट भी लिखा हुआ है ना यहाँ पे ऊपर, प्रीवियस इनटेक आउटपुट में मेंशन करोगे माइनस 1000 ml, so it is overflowed. That will be mentioned and reported to the concerned doctor. कंसर्न डॉक्टर को आप रिपोर्ट करोगे, तब क्या करेगा वो डॉक्टर? ही विल री-रिवाइज द प्रोग्रेस शीट. डॉक्टर विल री-रिवाइज द प्रोग्रेस शीट के हमें पेशेंट को इतना फ्लूइड दे दिया है, नाउ आई विल बैलेंस द डॉक्टर इनटेक आउटपुट ऑफ द पेशेंट. ठीक है, अभी सिर्फ इन्फ्यूजन लिए है और क्या लिया है? कुछ नहीं, इंजेक्शन लिए थे 1-2 बस. ठीक है, अभी सही है. Understood the intake output formula and what is the importance of intake output, right? So documentation is a very important part. Reporting is also very important part. I have maybe अभी तो हो रही है. Guidelines for charting है, accurate measure करें, record immediately, use standard units, 24-hour total होता है. So I have already told to you. Nurse's responsibility, fluid accurately, record immediately, same. Legal and ethical aspects, records are legal document, must not be altered or erased. It should be not erased, चिपकी नहीं लगानी, whiter use नहीं करना है, overwrite नहीं करना है. Nothing should be done on your documented sheet. Once you documented, that should be reported first, then only you can go for further documentation. Okay, it should be reported first, right? This is very important part. Maintain confidentiality. Always you have to maintain confidentiality. Follow hospital policies. This is also one of the main important part. कि आपको हॉस्पिटल पॉलिसीज को वो नहीं करना है, वॉइड नहीं करना. ऑलवेज गो विद द हॉस्पिटल पॉलिसी. एरर्स व्हाट वी डू इज इनकम्प्लीट रिकॉर्डिंग. कभी कभी हम क्या करते हैं, मैंने दवाई दे दी, डॉक्टर ने भी बोल दिया वर्बली, मैंने भी वर्बली कर दिया, बट वी आई हैव नॉट मेंशन इन माय ट्रीटमेंट शीट. सो अगर मैंने इफ आई हैव नॉट मेंशन इन माय ट्रीटमेंट शीट, पेशेंट को टर्मिडोल लगा दिया मैंने, या फिर टजार लगा दी एंटीबायोटिक, मैंने उसको डॉक्यूमेंट नहीं करा और 100 ml में था वो, तो फर्स्ट ट्रीटमेंट शीट में डॉक्यूमेंटेशन नहीं हुई है मेरी, पेशेंट का पैसा लग गया, मैंने एक दवाई मंगा ली उससे, उसका बिल कट गया है, लेकिन मेरे डॉक्यूमेंट में नहीं है, इट्स नॉट इन माय डॉक्यूमेंट. सो क्या बोला जाएगा? क्या बोला जाएगा? इट्स अ चोरी. is a you have taken from somewhere else and you have given to the patient, or you have not given to the patient and you have taken from the patient. Right? So to avoid all these things, you should always mention the treatment to in the treatment sheet. Okay? अब आपने वो 100 ml लिखा नहीं, तो आपके इनपुट में आ जाएगा? आपके इनपुट में आएगा क्या? No, it will not come to your input part also. So now what will happen? Your intake will be decreased or your output will be increased. So each part should be written properly, concise and accurately, and on the time of administration and on the time of doing or performing the things. Incorrect abbreviation we are using, sometimes we are using incorrect abbreviations. In our own words we are writing that no one can read or understand. Failure to sign, sometimes very important, if we have not signed somewhere in treatment sheet also, nurses also in our hospital, nurses are also having their registration number and name stamp. So all should put that stamp. You should check and you should, if you are given, you should stamp your treatment sheet. You should stamp your intake output chart. You should stamp your treatment in vital sheet. Everything should be signed. So conclusion is recording and reporting ensure safe patient care, help in communication and decision making, and accuracy and timeless are essential. So this was my topic. Some problems has occurred in PPT. From my side, I think I have given my best, or all has understood what I want to explain. Uh, because this is very important part of the hospital and a nurse. Thank you.
Sir, show के नहीं है screen screen के नहीं है full screen है समझ आ रहा है अंदर this is not नहीं आ Thank you, Professor Poonam Azad, ma'am, for your insightful session on recording and reporting. It was very informative session. Thank you, ma'am. For learning more, we are heading to the last session of second day of faculty development program. We have Miss Anvita Stanley, ma'am, and Miss Roma Singh, ma'am, PG nursing tutor, Rohilkhand College of Nursing, to discuss about bed making. We are heading towards the basic of fundamentals of nursing. Again, I hand over the mic to Miss Anvita Stanley, ma'am.
इस वाले कारण में दूध नहीं देता। लाइट से बस करो दोबारा। ये है कौन सी वाली? ये तो बोलते हैं।
मेरी पीपीटी नहीं चली इसमें। वो डब्ल्यूपीएस से बनाई थी। लॉग्ड होगा ना ये? है?
हम्म,
लॉग था।
नहीं।
डब्ल्यूपीएस से चली नहीं। खुली पहले खुल गई थी, फिर खुली नहीं, जिसने चेक किया था ना पहले।
इस पे ही दिखा रहा है फिर कैसे? पीपीटी है कहाँ पे? बंद कर लो दोबारा बोलो। पीछे की से खत्म हो गई ये सब? पीपीटी खुली है, कैंसिल हो गई सब ये? हाँ है। ये लास्ट से तीसरा। स्लाइड शो कर देते हैं अगर हम। आपकी हो ही नहीं रही थी पीपीटी, इस पे ही नहीं हो रही है। ये क्या सिलेक्टेड आ रहा है? इस पे नहीं हो रही ना, इस पे भी तो वही होनी चाहिए थी, फुल स्क्रीन पे तो नहीं आ रही है। और कोई पीपीटी देखें? और कौन सा देखें? खुली ना फिर तो इसमें ऑप्शन आ रहा है ये वाला। कुछ कर दिया आपने, कुछ पीपीटी तभी हो रहा है। कहीं से कोई ऑप्शन खुल गया है। तो ऑप्शन टिक हो गया है तभी हो रहा है। एक मिनट, इसमें ऑप्शन क्या खुला हुआ है? ये कौन सा है? कीप स्लाइड अपडेटेड। कहाँ से हुआ है बताइए। अरे एक्सटेंडेड कर रखी है एक तो ये काफी कौन सी ये है? कौन सी वाली थी?
Good afternoon, one and all over here, all the respected dignitaries and all the faculty members from Rohilkhand College of Nursing and Keshtata College of Nursing. I am Amrita Stanley, PG Nursing Tutor, along with Mrs. Roma Singh Ma'am, my co-partner of this session from Rohilkhand College of Nursing. Feel honored to stand here to present the competency-based hands-on clinical skill training workshop on bed making. Through this session, we will focus on developing practical skills and proper techniques related to different types of bed making in hospital settings. So the learning objectives are, by the end of the session, we will learn about meaning and importance of bed making, types of bed making, preparation and articles requirement of bed making, steps of open bed making in the hospital settings, steps of cardiac bed making, nursing responsibility during the procedure, maintaining patient comfort, safety, privacy during the procedure. We also learn about infection prevention and proper handling of the bed linen. Some common mistakes, we also learn to avoid these mistakes during the session. And last, application of bed making principles in clinical practices. So let's start with the introduction. Bed making is one of the most important nursing procedures performed in the hospital and healthcare settings. It is basic nursing skills that ensure patient comfort, cleanliness, safety, and prevention of infection. Proper bed making contributes to physical comfort as well as psychological well-being of the patient. So if we prepare a clean and wrinkle-free bed, it will help in various forms, like we promote rest and sleep to the patient, preventing bed sores, maintaining personal hygiene, enhancing patient satisfaction, prevention the cross-infection, improving the appearance of the ward, and last, bed making reflects the quality nursing care that provide in the healthcare institution. The definition of bed making under the NABH and modern healthcare protocols, it is defined as a critical quality assurance intervention designed to prevent hospital-acquired complications such as ulcers and cross-infection, while maintaining an aesthetically pleasing, organized unit that is immediately ready for routine or emergency patient care. Next, the objectives of bed making. So the core objectives of bed makings are, first is hospital-acquired infection prevention. In this, we mitigate the spread of aerosolized pathogens. Aerosolized pathogens means that type of pathogens who present in over the atmosphere and easily cross contamination. Next, zero harm patient safety. We secure patient mobility and mitigate the fall risk by assessing bed locking mechanism and optimize side rails during the procedure. We also reduce the pressure injury prevention. Next, continue monitor the patient. While making the bed, the nurse also observe and assess the patient condition like his or her comfort, skin condition, mobility, and overall well-being. Next is the standardized biomedical management. In this, we segregate soiled, infected, or fluid-soaked linen immediately at the bedside into the designated color-coded laundry bags without touching the floor. Next is ergonomic excellence. In this, we preserve healthcare worker safety by utilizing proper body mechanism and adjustable height bed features and reducing occupational musculoskeletal injuries. So for this, the nurse should have to remember that whenever we going to bend for doing the bedding procedure, do not bend from your back directly. You can also see the picture. हमें कभी भी बेड मेकिंग करते टाइम अपने बैक को बेंड नहीं करना है. बेड मेकिंग करेंगे तो हमारे पोस्चर ठीक होगा, कंफर्टेबल होगा. So first flex your knees downward, then you have bend from back side. सबसे पहले हमें स्लाइडली अपने जो लेग है उनको एक्सटेंड करना है लाइक दिस. फ्लेक्स करना है फर्स्ट लेग आगे करके लाइक दिस. Next, while tucking the linen, make sure your knuckles should be in upward direction, because when you tuck in the downward direction, your knuckles will get injured. So, also, while on the bed, we have to keep some distance from the bed so that we prevent ourselves from the infection. Next, some modern principles of bed making. So, our first and most important principle is control of infection and hygiene. In this, we minimize pathogen spread by avoiding shaking linens to prevent spread microorganisms into the air. कभी भी हमें Next, proper waste handling. Immediately place soiled linen into a designated linen hamper or laundry bag, not on a floor or chairs. Always doing hand washing or hand hygiene for before and after the procedure. Next principle is patient comfort and safety. In this, we always provide smooth surface that ensure our bottom sheet are taut and free of wrinkles to prevent the pressure sore. Next is secure foundation. We always use mitred corner, that is also known as hospital corners, at the foot of the bed to hold the sheet firmly in the place. Safe position. In this position, the open end of pillowcase away from the door to maintain the clean appearance and protect from the dark. Next is layering. Proper layer sheets with clean, high quality linen. For example, our bottom sheet, then Macintosh, then raw sheet over the blanket. That's the spread sheet. Body mechanism. Adjust the height of the bed. Elevate the bed to waist level to avoid the back strain. So the standard height of the hospital bed from the floor is usually about 60 to 70 centimeters, in inches 20 to 28, depending on the type of hospital bed and patient needs. ये height हम basically use का voice secure करके बनाएंगे. कैसा होगा? Next, the standard distance between two hospital beds is usually about 3 to 6 feet. This distance we maintain because we maintain the privacy of the patient and easy movement and infection control also. Next, the purpose of bed making. So the physical purposes are to provide comfort and relaxation to the patient, to maintain proper body alignment, to prevent pressure sore, to promote sleep and rest, and to maintain cleanliness and hygiene. The psychological purposes are to provide mental satisfaction of the patient, to create a pleasant environment, to improve patient confidence. Next, the therapeutic purpose of bed making, to prevent infection, to observe patient condition during the bed making procedure. Last, to promote recovery and healing of the patient. Indications. We all know कि अब हमें कब बेड मेकिंग करनी होती है. हम स्टूडेंट को हमेशा वही गाइड करते हैं. First of all, admission of the patient. Next, after discharge or transfer of the patient, when linen becomes wet or soiled, daily routine nursing care before and after the procedure to maintain cleanliness and infection control and during the patient comfort care. We have some precautions also. Although bed making is a routine nursing procedure, but certain precautions must be taken, like avoid excessive movement in a spinal injury patients. कभी भी कोई spinal injury patient है, critical patient है और a fracture patient, हम उसको बहुत ही limited move कराएंगे during the time of bedding procedure. Next, avoid sudden movement in critically ill patient. Use caution to patient with fractures. Follow isolation precautions for infectious patients. And last, always maintain the oxygen or IV line supplies properly during the occupied bed making. Next, there is some guidelines of bed making. Promote the patient comfort, prevent infection, protect skin integrity, maintain patient's dignity, prevents falls and injury, supports efficient nursing care. There are some pre-procedure assessment also. Before making the bed, assess mobility level of the patient. Next, assess the pain, skin condition, level of consciousness, presence of IV lines, drains, catheter reactions, or oxygen supplies. The risk assessments are pressure injury risk, fall risk, manual handling risk, and the infection prevention guidelines. In this, we perform hand hygiene before and after the procedure. Always wear the gloves when handling a soil-infected linen. Do not shake the linen and place soil linen directly into the laundry bag. Next, there is evidence-based nursing guidelines also for safe and effective bed making. So these guidelines are given by the international sources like World Health Organization, given hand hygiene and infection prevention guidelines during the bed making, and NABH and healthcare provider also give nursing and patient safety standards during the evidence-based practices. So बेड मेकिंग हमें लगता है कि एक बहुत ही सिंपल और कॉमन स्टेप है जो हम हमेशा फंडामेंटल नर्सिंग में स्टूडेंट्स को पढ़ाते हैं, बट एविडेंस बेस्ड प्रैक्टिस से हमें बहुत सारे रिसर्च के थ्रू हमें ये पता चला है कि हम कैसे पेशेंट की स्किन को सेफ रख सकते हैं, मिनिमाइज कर सकते हैं हम प्रेशर सोर्स को और प्रमोट कर सकते हैं ergonomic safety for the staff also. So by this picture, evidence-based practices in bed making, we use some principles. In this picture, there are total 13 principles. First of all, always wash hands before and after the procedure. Clean, dry, and wrinkle-free linen prevent the skin irritation and pressure ulcers. Do not shake linen as it spread microorganisms in the air. Use correct posture and techniques to prevent breath injury and strain to the nursing staff. Provide privacy, always provide privacy and keep the patient covered as much as possible. हम हमेशा हॉस्पिटल ग्राउंड पे जाते हैं और हम पेशेंट को देखते हैं अपने स्टूडेंट्स के साथ जब वो बेड मेकिंग करते हैं, तो बहुत ही लिमिटेड स्टूडेंट्स हैं जो बेड मेकिंग के टाइम पर प्राइवेसी मेंटेन करते हैं. तो हमेशा हमें स्टूडेंट्स को ये बोलना है, हमको इंकरेज करना है. At the time of bed making, always use privacy. Next, change soiled or damp linen promptly to prevent infection and promote comfort. Keep the bed smooth, dry, and wrinkle-free. Always use gloves. Place soil linen directly into the designated laundry bags without touching it. Make the bed according to the patient need. Keep the bed area clean and organized. Use side rails, lock wheels, and ensure safety of the bed making. And always follow the hospital protocols. So अगर हम ये सारे evidence based principles को follow करेंगे तो हमें कभी benefits भी इसके हमें present हो जाएंगे. Like हम प्रिवेंट करा सकते हैं हमारे हॉस्पिटल में एक्वायर्ड इन्फेक्शन को, प्रमोट कर सकते हैं पेशेंट कंफर्ट को, प्रिवेंट करेंगे प्रेशर अल्सर्स को, ensure patient safety and reduce the nurse injury and strain. So this is the evidence-based practices in the bed making. Next and most important, types of bed. There are different types of hospital beds are used to provide comfort, safety, treatment support, and proper nursing care. to patient according to their condition. Each bed serves as a specific purpose in patient care. So there are two types of bed divided into like simple bed and special bed. In simple bed, first there is closed or unoccupied bed, means the bed is ready for a new patient or a bed without patient in the bed. Next, the open bed. This is a type of bed that prepares for a patient who is able to get in easily. In this type of bed, the top covers are folded back to make patient entry conveniently. Next is occupied bed. In this, we made while the patient is still lying in the bed, it is prepared for the patient who are unable to get out of the bed due to some illness like fracture, weakness, coma state, or unconsciousness. There are special bed also, like first is post-operative or surgical beds. Next, the cardiac bed, fracture bed. You can see in the picture. Next is burn bed. In burn bed, we use bed accessories like bed cradle is a frame used to keep the sheet and blanket from lying directly patient while in the bed. So in burn bed, the bed cradle is usually kept about 15 to 30 centimeter or in inches 6 to 12 inch above the patient body to prevent the bed linen from touching the burn area directly. Next type of bed is amputation or divided bed. An amputation bed, also called divided bed, is a specially prepared hospital bed for a patient who has undergone amputation of a limb, like above the knee or below the knee amputation. There are some therapeutic beds also, renal or rheumatism or blanket bed. It is a bed made for patients suffering from rheumatism or renal disease. So the purpose of this bed is to carry the weight of the bed clothes of the painful joints, to keep the patient warm, to reduce the sweating. Now we are coming to the preparation stage. First, explain the procedure to the patient. Next, always check the concern if required. Provide privacy using curtains or screens. Ensure the comfort. Encourage participation if possible. This is cleaning solution method. In hospital, antiseptic or disinfecting solution for cleaning the bed is usually prepared according to the hospital infection control policy and the type of disinfectant we use. So the commonly used solution are, first is Savlon solution. So we all know the ratio is 1:20 and preparation is 20 ml Savlon add with the 1 liter water. If we use sodium hypochlorite solution, this solution is mostly used in HIV and HCV patient. So the 1% or 1 part solution we take and add with the 9 parts of the water. For example, if we take 9 water, we add with 100 ml sodium hypochlorite solution on it. After making the solution, we prepare the environment. Close doors, windows if necessary. Arrange articles nearby the setup. Ensure adequate lighting. Lock bed wheels. Maintain cleanliness and safety. The preliminary assessment are patient's physical condition. If we make occupied bedding, ability to cooperate, presence of pain or discomfort, presence of tubings, cleanliness of linen, environmental safety, and availability of articles or equipment. So let's start the procedure with the closed bed. A closed bed or unoccupied bed is a bed So closed bed or unoccupied bed is a bed prepared for a patient who is not currently occupying it. The top linens are arranged neatly over the bed to keep it clean and ready for use. Change. Change. So first, 6 folding methods of bedsheet. हम सबसे पहले बेडशीट को 6 मेथड से फोल्ड करना सीखेंगे. ये हमें इजी रहेगा ड्यूरिंग द टाइम ऑफ बेड मेकिंग जब उसको अनफोल्ड करेंगे. सो द फर्स्ट स्टेप इज फर्स्ट फोल्ड द लोअर पोर्शन ऑफ द बेडशीट. Then direct fold. Then fold the upper portion of the bedsheet toward the lower direction. By this step, your 2 folds are completed. Next, make the third fold from your side of the bedsheet. Then make the fourth fold from the opposite side, parallel to the previous fold. Now 4 folds are completed. Next, after that, bring both sides together from the front side and make the 5th fold. Finally, make a small secure fold of the bed sheet to complete the 6th fold evenly and neatly. This folding method helps the nurse to unfold the bed sheet easily according to the need and save the time. So the required articles are: first, mattress with cover to provide comfort, support, and proper body alignment. Next article is bottom sheet to cover the mattress smoothly and provide a clean surface. Next, Macintosh to protect the mattress from moisture and body fluids. Draw sheet to assist in moving and position the patient easily. Top sheet to cover the patient and maintain warmth and privacy. Blanket if required to provide warmth and comfort. Laundry bag to collect and transport dirty linen safely and prevent infection spread. Kidney tray to collecting the waste. Basin for preparing antiseptic solution. Mitten clothes or a duster used to clean the bed surface area. Antiseptic solution to clean and disinfect the bed surface, and gloves to prevent the cross infection. Always arranging the linens in reverse manners. That is, keeping the pillow first, then blanket, then top sheet, draw sheet, Macintosh, and bottom sheet. It will definitely save your time and energy during the procedure. Now let's start the procedure. First, arrange the article nearby the bed. First, next is make the hand hygiene by using all steps. Wear the gloves. Next, make a duster. Next, make a mitten by using the duster. Always keep your hand in upward direction. Make a duster in a mitten format like this. So let's start the dusting or cleaning the mattress. First, dip in the antiseptic solution and squeeze the extra water. Now take kidney tray and start dusting from our side to middle side in upward and downward stroke. एक बार क्लीन करने के बाद हम स्ट्रोक को रिपीट नहीं करेंगे उस एरिया में. We also clean the mattress in downward area. Next, if required, clean the mitten, dip in a same way, squeeze it, take a kidney tray and clean the mattress in different area in upward and downward direction. Same way, you clean the leg side of the bed. Next, also clean the cot. If required, clean the back side of the mattress also in same manner, upward and downward direction. Like if a positive patient, HIV patient, HCV patient, and there is some blood particles or mucus particles are there, you can clean the back side of the mattress also. Always in upward and downward direction. Clean the cot surface area also, middle side to our side. Next, clean the downward area of the bed also. Ensure all the surface, all the corners, all the areas of the bed must be clean. Next, remove the gloves and discard in a kidney tray. Again, hand hygiene. And wear the next or fresh pair of gloves. After wearing the gloves, take a bottom sheet in this manner. Then place the bottom sheet at the upper side of the bed and unfold it. Make sure the longitudinal crease will come at the longitudinal axis of the bed. First, unfold the upper side of the bottom sheet. Unfold the bed sheet. First, unfold the upper side of the bed sheet. After doing this, unfold the bottom side of the sheet. While unfolding the bottom sheet, you have to make sure that there is less crease or wrinkle-free area. After spreading this linen, we will tuck this first at the head end side. So for this, we will create mitted corner. In the hospital bed making, mitted corners are formed by lifting the sheet at approximately 45-degree angle to create a neat triangular fold. This technique helps and keep the sheet tightly, smoothly and secure under the mattress. First, layering the triangular fold of sheet on a bed. Then tuck the end of the sheet under the mattress. Pulling a triangular or 45-degree fold over the side of the mattress. Secure all the remaining parts under the mattress. You can see the corners. In the same way, we will tuck at the foot end side also and create the mitted corner. Check the smooth area. Next step is take the Macintosh, place it on the middle of the bed. Then we roll it like this. Always remember, leave 37 centimeters space from head and side. Next, we will take draw sheet and spread it over the Macintosh. First, unfold. Secure all the layers under the mattress. Take the top sheet. Use of this top sheet, we will place it below the blanket so that the blanket will not irritate the patient. Now unfold it. Tuck this top sheet at the foot end side. and make a mitten corner also at the foot end side. Secure all the partition of the top sheet. At last, if required, take a blanket, place it over the top sheet and unfold it in a same manner. First, unfold the upward area, then downward area of the blanket. Always remember, blanket should be 15 to 20 centimeter below the top sheet. Now secure the blanket under the mattress. Also make the mitted corner. Make one more fold at the head and side. And secure it under the mattress. At last, take a pillow with clean pillow cover and place it head and side. One thing, always remember, open end of the pillow should be away from the entrance or door to reduce the infection transmission. Now our closed bed is ready. All the linen are protected from the microorganism and dust. After the procedure, make sure all the remaining articles replaced in the utility room. Do hand washing or hand hygiene in a same way. In the same way, we make open bed also. We unfold the top sheet and blanket and make a triangular fold over the bed. Now this is our open bed receiving for the patient. Now remove all articles. Remove the used gloves. Do hand hygiene. Next, I would like to invite Miss Roma ma'am, PG Nursing Tutor of Rohilkhand College of Nursing, to come on the dais to continue the presentation.
Good afternoon to respected Principal Ma'am, KCN, RCN, Principal of Vice Principal Ma'am, RCN and KCN, and all faculty member and all dear students. As we know, Anvita Ma'am discussed about all bed types, and now I will discuss about the occupied bed making. So an occupied bed is made while the patient is still in the bed. This procedure is done for patients who are unable to get out of bed due to illness, weakness, paralysis, and post-operative condition. Next is purpose. To provide comfort to the patient, to maintain cleanliness and hygiene, to prevent bed sore and infection, to promote rest and sleep. So, occupied bed is for the patient who are not able to come out. These patients are very critical conditions, so need special our case scenario is patient having a 72-year-old female is admitted with right-sided cerebrovascular accident stroke. She has left side weakness, and unable to get out of bed immediately. So she is conscious but require complete assistance for the turning and hygiene. So which type of bed making we have to perform? So anyone guess which type of bed making? Occupied bed making. So because patient is not able to move and cannot leave the bed, so we are prepared occupied bed. So first of all, we arrange the all articles of patient side and start our occupied bed making procedure. So following steps to be followed. Firstly, general assess the patient condition, provide privacy, and always the article of patient bedside explain the procedure of the patient. Next, remove unnecessary equipment from the patient units and prepare the solution for clean mattress and bedside cleanliness. We prepare solution, one basin in plain water and one basin in Savlon water. So make a mitten. Firstly, make a mitten. Firstly, we remove the watch and wash your hands. So palm to palm, sorry, all four steps we are followed. Wear the gloves. If required, rise the bed a comfortable height to prevent back strain and promote proper body mechanism for the nurse. After the wearing gloves, put down side rails on both side of patient. And make up, first of all, we remove the dirty linen. We remove the dirty linen. First of all, We remove the dirty linen of patient side to loosen top sheet linen and ask the patient if she is feeling better, can sit on the stool or chair, place bedside the bed. If unstable, turn the patient gently to the one side of the bed and support with side rails. If not support, not conscious, the patient instruct the patient to hold the side rail opposite side. If not, if patient unconscious, so assistant or another nurse we take. So next step is roll all dirty linen. Roll all dirty linen and remove pillow of the bedside. Always be remember, whenever we remove bed sheet, we fold in rolling method. We remove in rolling method and discard in laundry bag. We roll it all Macintosh straw sheet and bottom sheet in rolling method and place in patient bag below the patient bed. Because contain microorganism and debris within the linen, reducing spread the contamination. And now make a mitten and clean the, dip the Savlon solution, dip the Savlon solution and squeeze and take kidney tray and clean the mattress lengthwise, top to bottom. Remove dust and microorganism in an organized manner, preventing missed area. So clean the mattress in top to bottom. And two part, always be two part divided in bed, and after that we clean the mattress. Clean the coat from near to far head and foot also. Use a systematic approach to ensure complete cleaning and avoid decontamination. Clean half of the food and clean part of side rails also. And after that, remove gloves and hand hygiene perform. And this cleaning method, if both sides of the patient, left and right, clean all the mattress in same manners. And place the clean linen on the empty side. Place the clean linen on the empty side. So spread properly. Always bed sheet fold in longitudinal way and first open with our side and next open with patient side and folding manner. and place the Macintosh always remember whenever fold our bed sheet, don't touch the dirty linen of the bed sheet, patient bed sheet. And make a mitten. Always be triangular manner, 90-degree angle create. And make Macintosh spread properly and folding patient's back side and draw sheet spread. After that, carefully turn the patient over the clean linen. Always remove of dirty linen and replace of clean linen without transferring the patient out of bed. And turn the patient in clean bed sheet and with the help of assistant, sidral can help to patient and dirty linen always be folding in rolling method and roll and discard in laundry bag. And repeat the procedure from both steps. Firstly, spread the bottom sheet and Macintosh properly and draw sheet and all the bottom sheet properly tucked. And make the patient lie straight in the middle of the bed. Pull clean linen and tuck properly. Patient make the lie straight in the middle of the bed. And place the pillow with pillow cover the patient head. Provide a clean surface for the patient head and reduce risk of infection. Make the patient comfort. Ensure proper positioning, warm and overall satisfaction. And after that, spread top sheet. With proper tucking the patient with proper make a mitten. And after that, we check all the patient side in any harm, any injury, and IV line is connected. So check properly IV line. And if patient so dispose of soiled linen properly after that. अगर हमारी बेडशीट ब्लड से डर्टी है या ब्लड लगा है तो उस टैब पे after that we prepare the cardiac bed. So cardiac bed is a special type of bed prepared for the patient suffering from cardiac disease such as heart failure, myocardial infection, or breathing difficulty. The patient is kept in the comfortable semi-sitting positions to reduce the strain on the heart and improve breathing. So what are the purpose? These are the equipments of the बेड में कार्डियक बेड में हमेशा हमें ये ध्यान देना है कि हम पेशेंट को अगर ब्रीथिंग डिफिकल्टी हो रही है तो हमें उसे सिटिंग पोजीशन यानी कि सेमी फाउलर पोजीशन एंड फाउलर पोजीशन प्रोवाइड करना है. सो सेम मैनर्स में सारे जो बेडशीट्स हमने बिछाई हैं वो सब वैसे स्प्रेड होंगी और उसके बाद पेशेंट को always be remember two pillow, always be support two pillow on patient backside and to support the head and back and arms. And if needed to backrest, head and rise, Fowler and semi-Fowler positions, side rails up to safety and support, ensure comfort and proper body alignment of patient, observe breathing and sign of distress, and always be patient bedside oxygen setup kept and ready if needed, monitor for continuous monitoring, cardiac table for placing food and medication, etc. If breathing difficulty in patients, so patient head down in cardiac table, clean smooth linen to ensure comfort and easy breathing. So these are the cardiac bed making and patients feel better. Thank you, ma'am. Next is after that surgical post-operative bed. So after operation, patient having received in post-op operation ward. So surgical or post-operative bed is a special bed prepared to the received patient turning from the operation theater. It is arranged in a way that allow easy transfer of the patient to stretcher to bed with minimal movement. Purposes is to receive the post-operative patient safely and comfortably to prevent shock and complication, to provide warmth and comfort, to allow easy observation and nursing care. So post-operative bed is necessary equipment nearby the patient bedside, oxygen, suction, IV stand, and whenever receive patient in post-op, so bed seat fold in, fan fold top clothes on the side, top expose the patient and make bed ready. So Top sheet always fan fold of the top close to the one side. And patient foot side hot water bag placed always to warm the patient, and lock the wheels always, and low positions. Keep the bed in low position for the patient's safety. So this prepare our post-operative bed. So this is our post-operative bed. Next is fracture bed. Two, ma'am. If necessary required, if not available in hot water bag bottle, so warmer we can use the post-operative ward to warm the room. Next is fracture bed. A fracture bed is a special type of bed prepared for the patient which with fracture easily of the spine, pelvis or lower limb. It provides firm support and helps maintain proper body alignment and immobilization. The purpose is to receive the post-operative patient safely and comfortably, to prevent shock and complication, to provide warmth and comfort, to allow easy observation and nursing care. These are the articles we use: the fracture bed, foam mattress and fracture board, bottom sheet, draw sheet and Macintosh, top sheet, blanket, pillow, sandbag. Always we remember this is the traction and fracture bed. जब भी हम फ्रैक्चर बेड के पेशेंट्स की बेड मेकिंग करते हैं तो हमें थोड़ा सा ध्यान देना है कि हम उसके इमोबिलाइज ज्यादा ना करें पेशेंट को, और वैसे ही हम उसमें स्प्रेड करें बेडशीट। एंड इन पेशेंट्स की बेडशीट को चेंज करने के लिए हमें पेशेंट के साथ अपने असिस्टेंट की भी जरूरत होती है, जिससे कि हम होल्ड कर सकें। इसमें ट्रैक्शंस लगे होते हैं। विद द हेल्प ऑफ ट्रैक्शंस की हेल्प से हम पेशेंट अगर इमोबिलाइज कर सकता है तो हम उसकी हेल्प ले लेंगे। Next is post-procedure care after steps. Ensure patient comfort. Place all bell with the reach, lower bed height, arrange patient belonging, remove dirty linen, clean and replace articles, maintain safety measures, and perform hand hygiene. Infection control measures during bed making. Some infection control measures and wash hand before after bed making, prevent transfer of the microorganism and cross infection. Wear the glove and use clean and dry linen. Do not shake dirty linen, fold soiled linen inwards. Keep clean linen away from unfold and not touch in floor. Change linen immediately if wet or soiled. Use separate linen for each patient. Disinfect hands after removing gloves. Follow hospital infection control protocol. Ensure safe standards nursing practice. Keep the surrounding area clean and ventilated. Reduce gown and spread with microorganisms. And some advancement in hospital beds. Hospital beds have changed from simple manual beds highly, and some hospital beds and different types of hospital beds. Semi-electrical bed is totally manual and electrical function. These are the semi-electrical bed and fully electrical bed. A fully electrical bed use motor or for adjustment, electrical adjust and head and control with a remote control panel. Some advancement includes standing bar for cushions. So these are the picture of advanced hospital beds. इसमें एक रिमोट कंट्रोल होता है जिसकी हेल्प से हम ऑल पोजिशंस पेशेंट को प्रोवाइड कर सकते हैं. ये फुली इलेक्ट्रिक तरीके से चलता है और मॉनिटर्स में कर सकते हैं. पेशेंट को हम अलार्म भी सिस्टम भी सेट कर सकते हैं और वेट भी हम चेक कर सकते हैं. ये फुली एडवांस है. इसमें हम ऑटोमेटिकली पेशेंट को रिमोट विद द हेल्प ऑफ रिमोट कंट्रोल से मूव कर सकते हैं. This is also hydraulic bed. This bed also in use in hospital. Most important bed. If patient is shifting in OT, emergency purpose, so this bed are always used for comfort and safety purpose. Patient care, post-surgery recovery and elderly care patient and ICU critical care and rehabilitation be bed always be used. Overall outcomes is patient safe, comfortable and relaxed and reduce infection and pressure ulcer. And always simple method evaluation is the bed clean, wrinkle free. Is the patient comfortable and safe? Where infection control practice followed? Is the environment neat and organized? Are the patient needs fulfilled? If yes, so these points are making. So case scenario, the question is, a 62 years old male, congestive heart failure, admitted severe shortness of breathing. He is unable to lie flat and become anxious when supine. So, which type of bed making should be prepared? So, anyone guess answer? Yes, right, cardiac bed. Because patient having congested heart failure and shortness of breathing. So, we provide cardiac bed. And also, 72 years female in admitted with the right side cardiovascular accident stroke. She has left-sided weakness and unable to get out of bed immediately. So, which type of bed making should be performed? Anyone guess? Anyone guess? Which type of bed making? Occupied bed. Yes, occupied bed because patient not having movement. So, we prepare the occupied bed. And some recapitulations. And today we will learn meaning of purpose of bed making, types of bed, principles of bed, evidence-based practice, and infection control measures during bed making. So these are the conclusions, and this is our reference. And thank you so much. Thank you. Thank you, Anvita ma'am and Roma ma'am, for a wonderful teamwork. Now I call Anita ma'am for the feedback.
So first I will start with the closed bed. The counter pan to be used to cover the bed. And the two dusters should be there, one is the dry duster and one is the wet duster. And 6 inches folding should be kept at the top sheet to prevent the foot drop. So if you are putting too tight, the foot drop will be present. So in order to prevent that, 6 inches folded should be left in the top sheet. And the draw sheet and Macintosh, it should be in the footed mode. It is in the top. Okay, it should be in the lower side.
It was a beautiful demonstration of teamwork makes the dream work. So now we have come to officially the end of second day of this competency-based hands-on clinical skills training workshop 2026. Gratitude is the art of saying the best wishes. So signing off for today, we will meet tomorrow for third day session as per the schedule, and delegates attending online, kindly fill the feedback form. It will be mentioned in the, it has been shared in the chat box. And facilitators of today's session, kindly make sure that articles are replaced properly. After that, delegates online can leave the today's session Zoom meeting. Thank you. Tomorrow the session will start at 8:30 a.m. sharp. Thank you so much.